Dear student, I am Dr. Prakash Mungli, Professor of Biochemistry. So in this lecture, I will be going over beta-thalassemia. Let's get into the details. In beta-thalassemia, beta-globin is either decreased or absent. So it is because of a mutation in a gene that is coding for a beta-globin, or it may be because of a deletion in a gene that is coding for beta-globin. Now the beta-globin gene has two copies, one on each chromosome number 11. Most patients with beta-thalassemia have a single base substitution, and the beta-thalassemia trait are minor. It is seen in individuals with the mutation or deletion in a single beta-globin gene. Whereas beta-thalassemia major, it is seen in individuals where a mutation or deletion happens in both the beta-globin gene, and that makes the difference between beta-thalassemia trait, who are usually the carriers of beta-thalassemia, whereas beta-thalassemia major is a symptomatic condition. Since beta-globin is required for adult hemoglobin, so the clinical manifestations of beta-thalassemia, it is seen several months after birth. Usually it takes 3 to 9 months for signs and symptoms to appear. Now let's look at beta-thalassemia trait, which is also called as beta-thalassemia minor. So the defect here in beta-thalassemia trait is one of the two beta-globin gene is defective or it is deleted. Because of this, 50% of the beta-globin is not synthesized and only 50% of the useful beta-globin is synthesized. And because of this, patient will show mild to moderate hemolytic anemia. Other than mild to moderate hemolytic anemia, generally patient do not show any other major signs and symptoms. So in the peripheral smear, patients with beta-thalassemia minor will show hypochromia, like hypochromic red blood cells, microcytosis, small red blood cells, target cells, and also mild poikilocytosis, that is change in the shape of the red blood cells. Usually these patients, they do not require any specific treatment. Coming to beta-thalassemia major. Beta-thalassemia major is commonly seen in people of Mediterranean region, African region, and Southeast Asian region. The beta-thalassemia major is because of either mutation or deletion in both the beta-globin genes, thereby production of beta-globin chains is severely impaired, and that leads to imbalance in the globin chains when hemoglobin is made. That means having lack of globin chains, there will be simply higher alpha globins and lack of beta globins to make a pair. So in this condition, what will happen? So this higher amount of alpha globins, which are normally synthesized in beta-thalassemia major, so there will be unpaired alpha globins which will accumulate, making α₄ tetramers, and these α₄ tetramers are toxic inclusion bodies, and they will destroy the red blood cells, because red blood cells containing these toxic inclusion bodies will be taken up by the reticuloendothelial system present in the spleen, and that will reduce the lifespan of red blood cells, which results in ineffective erythropoiesis. That means erythropoiesis is going on in the bone marrow, but it is simply ineffective because the red blood cells that are coming out of the bone marrow, they contain inclusion bodies which are α₄ tetramers, which are made in the absence of beta globins which are not synthesized. So because of this ineffective erythropoiesis, because of the rapid lysis of this inclusion body containing red blood cells, there will be severe microcytic hypochromic anemia in beta-thalassemia patients. So because of the microcytic hypochromic anemia, so there will be lack of oxygen that is carried from lungs to the peripheral tissues, and this lack of oxygen in the blood is sensed by the kidney and it is going to release erythropoietin. And the erythropoietin, it's going to stimulate bone marrow, and bone marrow is going to increase erythropoiesis, and the kind of red blood cells that are coming out of the bone marrow, again they contain inclusion bodies, and these inclusion body containing red blood cells will be removed from the circulation by the splenic sinusoids, and microcytic hypochromic anemia continues, erythropoietin is continued to be released, and bone marrow is continued to be stimulated, and that will lead to compensatory erythroid hyperplasia in the bone marrow, leading to widening of the bone marrow and thinning of the cortex of the bone. And this may lead to massive expansion of the bone marrow space, and the cortex becomes thin, and that may lead to pathological fractures in the long bones. And also, when the bone marrow is not sufficiently taking care of this severe microcytic hypochromic anemia, so the extramedullary erythropoiesis is initiated, especially in the liver and spleen. So the hematopoietic stem cells in the liver and spleen are reactivated to participate in erythropoiesis process. So that is what is called as extramedullary erythropoiesis, and that is seen in beta-thalassemia major. So because of the widening of the marrow space in the long bones where pathological fractures can be seen, even the flat bones are also involved in the erythropoiesis just to compensate for the microcytic hypochromic anemia there. So since flat bones are also involved, so the medulla of the flat bones are also widened, and that will change the normal anatomical structure of the flat bones, and that may lead to changes in the facial features. So that is like changes in the skull leading to hair on end appearance, changes in the face leading to chipmunk faces, and widening of the bone marrow in the long bones leading to thinning and pathological fractures of long bones and also the vertebra. Now, hemolytic anemia causes hepatosplenomegaly, leg ulcers, gallbladder will show calcium bilirubinate stones, and also since anemia is severe, it will lead to high output congestive cardiac failure in these patients. Coming to peripheral smear findings in beta-thalassemia major patients, there will be microcytosis, small red blood cells, anisopoikilocytosis, that is variation in the size and shape of the red blood cells, prominent target cells are seen, and hypochromia with the hinge bodies, that is the red blood cells containing a denatured hemoglobin molecule beneath the cell membrane can be seen. These are inclusion bodies there. So these are some of the findings that we see in beta-thalassemia major patients peripheral blood smear. Now let me explain you the treatment for beta-thalassemia major. The long-term transfusion therapy is needed to maintain the patient's hemoglobin level at 9 to 10 grams per 100 ml of blood. This will suppress extramedullary hematopoiesis and skeletal changes in these patients. And then erythroid maturation agents like luspatercept is given, and this luspatercept decreases abnormally elevated SMAD2/3 signaling and improved hematology parameters associated with ineffective erythropoiesis. So, luspatercept, what it does is, it is going to decrease abnormally elevated SMAD2/3 signaling, and thereby it improves hematology parameters that is associated with ineffective erythropoiesis. Iron chelation is done to avoid complications of iron overload such as cardiac and hepatic dysfunction. Some of the iron chelators that are used here is desferroxamine, which is used intravenously, deferiprone, which is used orally, and deferasirox, which is again used orally. And note that deferiprone is particularly effective for cardiac iron removal and is therefore recommended for use in patients with significant cardiac iron loading or iron related cardiac disease. So make sure you remember that point with deferiprone. Splenectomy is done to decrease transfusion requirements, and allogenic hematopoietic transplantation can be done, and which may be curative in some patients with thalassemia major. Gene therapy can be done in beta-thalassemia major. So there can be two types of gene therapy that can be attempted here. One is autologous hematopoietic stem cells therapy, where autologous hematopoietic stem cells are harvested from the patient and then genetically they are modified with the lentiviral vector expressing a normal globin gene. So the other type of gene therapy that can be tried here is genome editing technique. So here in this technique, a zinc finger nuclease, that is ZFN, and transcription activator like effectors with focal nuclease, that is TALEN, or the clustered regularly interspaced short palindromic repeats, that is CRISPR, with Cas9 nuclease system, that is CRISPR-Cas9 system, can be used as a gene editing technique for treatment of beta-thalassemia major. Coming to investigational therapies, inducers of fetal hemoglobin can be tried like butyrates and hydroxyurea. Demethylating agents like decitabine 5-azacitidine can be tried. Histone deacetylase inhibitors like vorinostat, panobinostat can be used or can be tried in beta-thalassemia major. Remember, these are all investigational therapies that can be tried. Immune modulating agents like pomalidomide can be tried. Short chain fatty acid derivatives like arginine butyrate, sodium phenyl butyrate can be tried. And sotatercept, which is ACE011, is a promising activin type 2 receptor fusion protein that has been recently reported to improve anemia in patients with non-transfusion dependent thalassemia intermedia. So this is something that can be tried. And also autologous CD34 hematopoietic progenitor cell transduced with lentiviral vector encoding the normal human beta globin gene can be tried. So these are all some of the investigational therapies that can be tried in beta thalassemia. So there is significant development towards the treatment of beta thalassemia major, including gene editing techniques and so many investigational therapies which have been tried in curative treatments for beta thalassemia major. So that's all about beta thalassemia. I hope this lecture has helped you to understand the beta thalassemia and also to understand variety of treatment modalities that are there for beta thalassemia treatment. Thank you.